This is a live video recording from Radiopedia's 2015 Adult Brain MRI Review course, featuring Dr. Frank Gaylord and Dr. Andrew Dixon. For more information about Radiopedia courses, visit radiopedia.org/courses. If you are showing this video to a group, then please do the right thing and contact events@radiopedia.org to purchase a group license.
So, intraaxial supratentorial masses. So when I first started putting this together, and I was aiming for 25 minutes, it was coming in at about 70 minutes. So I thought, that's great for me, who loves to talk about tumours, but probably not so great for everyone else. So we've split it off a few topics into videos that will become available post-course, which are really a little bit more advanced and probably not that relevant to many of you. We can divide parenchymal supratentorial tumours into tumours and non-tumorous masses. And some of these are really hands-off masses that you need to be aware of so that you don't resect them or biopsy them. And possibly these ones and cerebral lymphoma are the ones that are the most important part here, because all the other ones, you're going to take a piece of it, and if you're wrong, it's okay, you just get the correct answer. But in some of these, it's a disaster if you resect them. And infections, we've moved into a completely separate talk. So starting with primary parenchymal tumours. Importantly, everything I'm going to tell you now in the way that we describe tumours is going to be obsolete by March next year, because the WHO classification is in its draft format and is coming out in March. And although it'll keep histology and macroscopic appearance similar to how it is now, it's going to include molecular subtypes, much more front and centre of the classification. Specifically, IDH1 and 1p19q co-deletion will form a really significant part of how we classify tumours. And the challenge for us as radiologists will be finding imaging biomarkers that allow us to predict what these will be. And why do we need to predict this? Well, mostly because we need to be able to help our oncologists and surgeons interpret the histology report when the pathologists have looked at 1% of the tumour. And so undersampling is a major problem. And that's, I think, where radiology has the greatest immediate role to play. And the future role is hopefully we don't need histology at some point. If we can get good enough at predicting histology based on imaging, you can in some cases forego the need for biopsy. That's sort of longer game. So diffuse gliomas, this is a post-course video that will be available and just talking a little bit about these markers. But sticking with what will be still in general usage for the near foreseeable futures, we divide glial tumours really into astrocytomas, oligodendrogliomas, ependymomas, choroid plexus papillomas make it into the list, as do some of these other low-grade subtypes, which we'll discuss separately. Astrocytomas are the ones we are most used to because they're by far the most common, and we divide them into localised and diffuse. And this is a very pragmatic division because localised you can largely cure patients by resection, whereas diffuse you cannot cure patients by resection, and until the advent of better chemoradiotherapy, basically every patient with a diffuse astrocytoma would die of that tumour within a number of years, depending on grade. We're seeing longer and longer term survival with combined therapy, but surgery is only part of the arm and cannot, despite what some surgeons claim, effecate a cure in the vast majority of patients. So pilocytic astrocytoma is the only one that I'll talk about in this lecture. The other ones will come later today. We're used to thinking of them in children as being posterior fossa masses with a mural nodule and a cyst. And this is a very typical appearance in a child. No big flow voids, kind of just vividly enhancing nodule. And you can be fairly certain of the diagnosis. In adults, they don't look like this. And it took me a long time to realise that pilocytic astrocytomas are, one, not that uncommon in young adults, and two, can look like anything, but usually the one thing they don't look like is a pilocytic astrocytoma in a child. They have a propensity to be around the ventricles. They can and usually do have a cystic component, but the mural nodule is usually very ugly and heterogeneous with blood products and calcification. There's edema. They don't behave as benignly as those in children, with much higher recurrence rates. And it's a shame that when we think about division of demographics, we think pediatrics and adults as if you suddenly graduate to this new one and you get a different bunch of diseases. But the young adult group has its own subset of tumours, and pilocytic astrocytomas are actually really common if you have a young adult with a funny looking tumour. And we'll come across diffuse pilocytic astrocytomas again later on today. So the meat and potatoes of diffuse astrocytomas is the low grade and GBM with anaplastic falling somewhere in between. And this also is not very well publicised, is that when we talk about diffuse astrocytoma, we invariably mean, Dixon, we invariably mean fibrillary diffuse astrocytomas. And this is just according to subcell type. But there are a number of other subtypes which are important because they don't look anything like diffuse low-grade astrocytomas. And again, the main importance of this is interpreting histology and trying to work out where you've undersampled or where you're willing to accept the histology, and that's been moved into a post-course topic. But just to give you a flavour of what each of these looks like, fibrillary is the one we all know and love as a low-grade diffuse astrocytoma. It's high on T2. It's got a very smudgy transition point where it's hard to decide when you've gone from what looks like obviously normal white matter to what's obviously abnormal. Somewhere in between here is the transition, but it's not a sharp line. And we know that histologically, pretty much everywhere you have high T2 signal, you have tumour cells. And in fact, we know that probably 1 to 2 centimetres beyond that high T2 margin, we still have tumour cells. And so trying to resect is bound to failure because you almost invariably get tumour recurrence at the margins. Something that's not quite as readily recognised is that there's two components to this high T2 signal, and when you're interpreting these images, I think it's worth you focusing on them separately. One of them is what looks like vasogenic edema, and to a degree is vasogenic edema. It's edema, accumulation of extracellular fluid, and it spares the cortex as you expect it to, and it runs along white matter tracks, taking with it cells, and so there's long infiltration. But see how the cortex here is spared. The other component is non-enhancing cortical tumour, like here, where the cortex is thickened, becomes hyper-intense, and you lose that grey-white matter differentiation. And it's this feature that's particularly helpful when looking at secondary glioblastomas, in other words, those that have arisen from a low-grade tumour, versus metastases that you try and focus on. Because if you can find non-enhancing thickened cortex, it makes it very unlikely to be metastasis. T2 is actually easier to see these two components. We can see that down back here we have normal white and grey. Here we start getting abnormal white matter. The cortex is maybe a little bit bright, but by the time you get to the front, here it's very thickened. And when you see this appearance, there's really very little else that this can be when it's this size. Focal cortical dysplasia, a large area of focal cortical dysplasia, is worth considering, and the presentation will be important in terms of limbic encephalitis or HSV encephalitis. They don't enhance because they have nicely intact blood-brain barrier and don't have a lot of neovascularity. And in terms of their diffusion, we really don't see very much restricted, mostly facilitated, so brighter on ADC. Now, I hope you've had a chance to look at the diffusion-weighted video. If not, please do. I think you need to get used to looking at ADC maps. DWI maps are easier on the eye, but they're actually really confusing because they include T2 signal and you're not quite sure what's going on. Get used to just looking at ADC maps, and it's just much easier to work out that here we have facilitated diffusion, so it's not a very cellular tumour. Gemystocytic astrocytomas, on the other hand, look entirely different, and it depends on what proportion of the astrocytoma is made up of gemystocytes. We call gemystocytic astrocytomas when there's 20% maybe. The pathologists can't make up their minds. We know that as little as 5% gemystocytes carry a much worse prognosis. But when you have a tumour that's mostly gemystocytes, they look like this. They're very heterogeneous, often have large cystic areas. They have areas of nodular enhancement or wispy enhancement along the margins. Now, you'd be very forgiven for thinking that this was a high-grade tumour. There's a few features that are helpful in thinking that this is not a high-grade tumour. And the first thing is that high-grade tumours have their non-enhancing cystic or fluid component as an area of necrosis embedded within a larger enhancing tumour because it's the centre of the enhancing tumour that outgrows its blood supply. Whereas with these lower-grade tumours, the cyst tends to be peripheral with the nodule off to the side, and if there is enhancement, it's very thin and regular. The other thing is that typically these are in younger patients, slightly older than the diffuse astrocytoma, but still younger. And the degree of surrounding edema is probably not as much as you'd expect in a GBM. Difficult to be certain of these, and you really do await the histology. Protoplasmic astrocytomas are sort of in between the two in terms of their weirdness looking. They do appear more like a diffuse fibrillary, but they've got a couple of notable differences. The first thing is that they've got a very sharp zone of transition between white matter and normal and abnormal signal white matter. And the second on flare is that the large areas of these tumours demonstrate this signal drop or partial attenuation on flare. Now, it's really important that you don't call this cystic. There's two reasons why that's important. One is that you're wrong. It's not cystic. This is just gelatinous, really water-laden extracellular brain. The other thing is that if a surgeon believes you, and hopefully they won't, then when they're operating, they'll be waiting to get into a cyst. And not finding a cyst might lead to confusion as to where they are. So just call these areas of partial flare suppression. And when you see more than 50% or so of your mass looking like this, odds are that it's going to be a protoplasmic astrocytoma or an oligoastrocytoma, which look almost identical. And it sounds like they look almost identical histologically as well. Anaplastic astrocytomas look intermediate between diffuse and GBM, so I won't actually show you one because they're always kind of unrewarding tumours to look at. But glioblastoma, which is unfortunately the most common tumour, is characterised histologically and under the current WHO classification as having areas of necrosis and areas of neovascular proliferation. And importantly, the vessels are heaped up, so it's not just more normal vessels. The vessels themselves are abnormal. They have abnormal walls, they have abnormal blood-brain barrier, and so they leak a lot of gadolinium into the interstitium along with a lot of fluid, and so you get your edema and your enhancement. Importantly, you can get enhancement without this. You can get enhancement just due to blood-brain barrier breakdown without new vessels, and so that's why anaplastic astrocytomas tend to enhance even though they don't have neovascular proliferation. And remember that enhancement in MRI is due to accumulation of gadolinium in the extravascular space largely, whereas in CT you're looking much more at intravascular as well as leakiness. So you can't confuse capillary density or vascular density on MR with enhancement. They're separate things, and for that we need perfusion, which we'll get to in a second. The end result, though, is a very heterogeneous, ugly tumour, broad zone of transition, areas of hemorrhage, areas of necrosis. And when you see an enhancing lump with a central area of non-enhancement, with all peripheral heterogeneous enhancement around the margin, you can almost be certain that this patient is going to die of a high-grade glioma, regardless of what the histology tells you. And if the histology tells you it's a grade 2, most likely they've undergraded it. So what do these look like? Well, let's look below the tumour. So this location, we don't have any enhancement, and we see a very similar appearance to the diffuse low-grade astrocytoma. We again see this thickening, non-enhancing cortex sign, if you want, with subjacent white matter involvement. Note the deep white grey matter is also involved, which is helpful because vasogenic edema tends to wash along white matter tracts but tends not to invade the much more densely and compact deep grey matter structures, whereas astrocytomas have no such misgivings with enlargement here of both the caudate head and the lentiform nucleus. But when we come up to the enhancing component, we can see this mass with central flare suppression, which is very bright on T2. Again, probably worth not calling this cystic. This is an area of necrosis. It's not lined by a layer of epithelium. But you would expect a surgeon to get into this and to find dirty, dead tumour juice. On enhancement, this is where you really need to get your eye in. It goes all the way around and it varies in thickness from thin to lumpy areas. And that's because all of the enhancement is tumour with areas that have died off. The enhancement is not an organised response to an insult, which we'll see in abscess and to a lesser degree tumour factor demyelination. We won't look at this map because it's terrible, but diffusion restriction is important in these tumours. And important to get used to measuring ADC values. So ADC should, on all your scanners, be reliable numbers. We're not used to having reliable numbers on MR, but ADC is not the case. These are like Hounsfield units on CT. You can put a ROI and measure it off. The unit is unfortunately variably reported as either 10 to the minus 6 or 10 to the minus 3 millimetre squared per second because it's a measure of how easily water diffuses through that tissue. Now these are grade 2 tumours, these are grade 4. You'll notice that there's a significant difference between the values of the solid component, with highly cellular tumours having much lower ADC values. And this is quite helpful, not only in helping you come down to a diagnosis if you're hesitating between grade 2 or higher grade, but also helpful in trying to get your surgeon to biopsy the highest grade component. And that's critical because admission to clinical trials in Australia is largely restricted to grade 4 tumours. So if you don't get the highest grade component, you're excluding your patients from possibly life-extending, significantly life-extending therapy, or condemning them to having to wait till their tumour progresses and re-biopsy them to get confirmation of a grade 4. So if we have a look at this high-grade tumour involving the splenium of the corpus callosum, DWI, you don't know how much of this is T2 shine through and how much is true restriction, but if you look at your ADC map, this area here has much lower values than anywhere else. And by lower, we mean similar to normal brain. So by the time a glioma gets ADC values similar to normal brain, you're looking at a very cellular high-grade tumour. You don't need to be darker than normal brain to get that. So values of about 700, 800 are usually grade 4. And so reporting this would be helpful in mentioning that the region that appears to have highest cellularity is located on the left, just next to the splenium. Comment also on whether it enhances or not, and cerebral blood volume. But try and, if possible, to get biopsy from that area. And while we're on the topic of discussing post-therapy or biopsy therapy, pseudoprogression is a scary term, but it need not be. And it's merely the term that denotes is apparent progression on imaging due to tumour growth, or is it due to therapy response? It does not mean is there tumour or isn't there tumour. Because as we said before, you never get a complete resection. So if you do biopsy pseudo-response, you almost invariably get some tumour. But the question is what looks like progression due to tumour growth or not? And in this example, we have a patient who had a GBM, completely resected the enhancing component, but we know there's tumour cells going back to here probably. And we do it day 1 post-op, or within 48 hours of surgery, because you don't want your post-operative normal reactive enhancement to confuse the issue as to whether or not you've got all your enhancing component resected. 4 months later, which is a typical time for pseudoprogression, about a month after combined chemoradiotherapy has ceased, develop this nodular region of enhancement at the posterior margin, which is exactly where you'd expect a tumour recurrence to occur, near the resection where we might have left behind just a small amount of enhancing tumour. You cannot tell the difference reliably between pseudoprogression and tumour on post-contrast imaging alone. You really do need to perform perfusion, cerebral blood volume, and MR spectroscopy. And then when you do these two, it's quite simple. Pseudoprogression has no elevation of cerebral blood volume and has a pretty hypometabolic trace, so no obviously discernible peaks, or you might have just a lactate peak, but no choline, no NAA, because all of this tissue is necrotic and dying and doesn't have good blood vessels. If you see the two, you really should try and push the pseudo-response angle, because just waiting a month, you'll see that it starts to fade away or not grow. And this patient, just to give you an idea of how much we've progressed in the management of GBM, 5 years later, they're not only still alive, but this has just faded over time and they don't have a local recurrence. So I think in the future we have bright days ahead for patients with GBM, going from universal mortality within 3 months of diagnosis only 10, 15 years ago to now extended life for many patients. Oligodendrogliomas is the last glial tumour that we'll speak about. The textbooks, typically older textbooks, will always show an example like this. And the kind of values that you get are, they'll say 90% of oligodendrogliomas calcify, and that's coarse calcification, etc. The reality is we see this very infrequently. Very infrequently. I had to hunt for this one. I hadn't even come across one in daily practice. The vast majority of the oligodendrogliomas we see don't enhance, and they look like this. They look almost identical to protoplasmic astrocytomas. They have a very sharp zone of transition between abnormal and normal looking white matter. And the one thing they tend to do is involve cortex a lot. So a significant portion of the tumour is cortically based with a lot of gyral expansion. and they typically don't have calcification. They do sometimes enhance more than you expect them to, and they can have elevation cerebral blood volume, which is unfortunate because all of these in diffuse fibrillary are markers of higher grade and higher biological activity. And so when you're thinking of oligodendrogliomas, don't wait for them to calcify. And be aware that CBV can be elevated not because they've got neovascularity, but because they've got these, well, they do have neovascularity, but it's not hyperplastic abnormal vessels in the setting of GBM. It's these referred to as staghorn or chicken wire vessels, which just give it greater CBV. So in the setting of oligodendroglioma, you're willing to accept higher CBV values without thinking that what you're looking at is a higher grade tumour. Moving on to cerebral lymphoma. I won't show very much CT today, but cerebral lymphoma is worth noting that it's very hyperdense on CT due to the very packed cell nature of these tumours. And on MR, it's got a number of characteristics that should enable you to make the diagnosis with a high degree of certainty. The first thing is it's got a predilection for the borders of the brain, usually periventricular, but can be also cortical. It tends not to just meander around in the white matter. It vividly enhances and has this sharp but slightly smudgy border of enhancement. And we'll see that repeatedly. And often it's multiple. Again, periventricular with a sharp but slightly mudgy appearance. Here it's exophytic into the ventricle. We see another focus over here. And because it's so cellular, it has very vivid restricted diffusion, bright on DWI, dark on ADC. This pattern is what you need to remember. Hyperdense on CT and dark on ADC is a highly cellular tumour. And it might not be lymphoma, it might be medulloblastoma, or it might be pineoblastoma, but it's a highly cellular tumour, and those go very closely together and help you predict the histology. The enhancement of lymphoma is what's particularly helpful. And they all have this very homogeneous, even when it's cortically based, very bright as meningiomas, even more so and even more homogeneous. And you can be very certain of the diagnosis. And it's important to be certain of the diagnosis because if you put this patient on steroids, not only will the enhancement vanish within a few days, but trying to biopsy them, even if you get into the middle of a still enhancing lesion, often will give you a non-diagnostic histology. And so you're left with the temptation to keep biopsying these patients where they don't have a structural mass. It will be treated by chemoradiotherapy, although recurrence is really common. So you need to stick to your guns. And sometimes we treat on the basis of imaging alone, especially if the first attempt has failed. The one caveat to this is if your patient's immunosuppressed, lymphomas don't look like they're meant to. They look like everything else. Unfortunately, immunosuppressed patients not only are more likely to get everything else, but they're also more likely that everything looks a bit the same. Centrally non-enhancing, located wherever it kind of wants, lots of edema, very heterogeneous, ugly tumour. Very difficult to distinguish this from a high-grade glioma, difficult to distinguish from toxoplasmosis. And we'll talk about a couple of those later on. Metastases we see a lot of, especially as patients are surviving their systemic therapy more and more. And then sometimes we see them overrepresented because a systemic therapy doesn't get into the blood-brain barrier and therefore the brain acts as a reservoir of disease. It's particularly the case with HER2-positive breast cancer where we see brain recurrences really frequently. And I put this case up here, and this was one of the quiz cases that we put, not because it's metastases, but because it's very tempting to call it metastases because you have 3 enhancing lesions. And I think as medical students, we're always taught multiplicity is the key feature of metastases. Well, the thing that makes this very unlikely to be metastases are a number of things. Firstly, they're all aligned in a nice straight line along white matter tracts. And we know that this is how GBM spread, whereas metastases don't spread in the brain. They just arrive there by vascular supply, so they're random. If you want, they form triangles in some plane. And the other thing is that one of these lesions is in the splenium, or in the corpus callosum. Metastases almost never go to the corpus callosum. It's very unusual. I haven't got a case of a metastasis to the corpus callosum. I'm sure they occur, but they're very uncommon. When you see this, you can basically limit your differential to high-grade glioma, lymphoma, maybe radiation necrosis, or post-traumatic if there's a history. Look carefully at this mass. because this could easily be a MET. It's sort of at the grey-white matter junction. We really struggle to see that non-enhancing cortex, which we look for carefully. In this case, you don't see it. So this is what we would refer to as a multifocal glioma, in that there's multiple areas of enhancement embedded within the one larger area of T2 abnormality. The other term you sometimes see is multicentric glioma, which is where enhancement are in completely separate parts of the brain with no intervening white matter signal abnormality. So if you see this pattern, glioblastoma is almost certainly the answer. Metastases can look like whatever they want, pretty much. They range from almost entirely solid when they're small to peripheral thin enhancement that sort of looks like an abscess to almost entirely cystic where they look a little bit unusual. And they don't have to be multiple. Probably 50% of the metastases we see are single. And so distinguishing them can be very hard. I think this is probably one of the mistakes I make most often, the inability to distinguish a high-grade glioma from metastasis. It's just not that easy, especially because most patients, well, a lot of elderly patients have some history of malignancy in the past that's been treated. And don't feel too bad if you can't tell them apart. The one that you should be able to tell apart, though, is hemorrhagic metastases. And in Australia, we see a lot of them because of melanoma, although that's not as common in other parts of the world. The other typical primaries are thyroid, choriocarcinoma, and renal cell carcinoma. And by that we mean that the majority of the metastases from these primaries are hemorrhagic, but breast and lung can also be hemorrhagic sometimes, and because they're such common tumours, you see hemorrhagic versions of those metastases not infrequently. And here we have one patient that shows a number of different features of hemorrhagic metastases. This is the enhancing blood sponge appearance, where you have low T2, intrinsic high T1 because of hemorrhage, but the hemorrhage is interspersed amongst a still viable tumour so that the whole thing enhances. Up in the frontal lobe we have what looks more like a cyst, high T2, lowish T1 with a mural nodule and some peripheral enhancement. And the same patient in the posterior fossa also had this very intrinsic high T1 signal lesion. So when you see that pattern, this is a very unusual pattern even for any one of these solitary lesions to be a high-grade glioma, and you can be almost certain that these represent metastatic hemorrhagic tumours. Now to finish off this talk, we'll look at non-neoplastic masses. Tumour factive demyelination, I think, is one of those that's extremely important to get right. If for some reason the diagnosis was not suspected and this was thought to be a glioblastoma and an attempt was made to do a big debulking, you would end up with a terrible surgical outcome in someone who will probably get better and not have any sequelae. So what are the clues? Well, firstly, we saw in the previous one where the grey matter was involved. Here it's really looking at a white matter process. Both the demyelination and the edema is confined to the white matter. So it's spreading along white matter tracts, sparing the deep grey matter structures, but spreading along the posterior limb of the internal capsule. And the vasogenic pattern of edema is really quite striking, with complete sparing of the overlying cortex. It can spread across the corpus callosum, so that's why it's on the differential for those corpus callosal lesions. But the real clue is when you look at the contrast enhanced images. And the enhancement can vary from very vivid, almost lymphoma-like, to subtle, as in this case, but it tends to be at the periphery of the lesion, often without very much edema seen beyond it. It can be a little bit, but often not very much. And it's this grass fire appearance. It's at the edge of the advancing front of demyelination. That's where all the action is. There's your body's reaction to this demyelination is causing the enhancement, and it spreads along until it abuts something that doesn't burn, grey matter. So where it hits cortex or it hits bad, deep grey matter, it stops enhancing, and you end up with this open ring sort of enhancement, which is also characteristic of multiple sclerosis in smaller lesions, small C-shaped regions of enhancement. And when you see that, you really want to be quite forthcoming that this is likely to be tumour factive demyelination, and try and hold off biopsy if at all possible. The other lesion that can cause problems is radionecrosis. We don't see that as much these days with much better radiotherapy technique. These 3 patients all had radiotherapy to nasopharyngeal carcinomas 20 years ago, and sometimes the history is lost if the patient's demented. And they show nice, unfortunate examples of radionecrosis of all sorts of different types in their temporal poles that were included in the radiation field. Sometimes it just appears as vasogenic type edema, sparing of the cortex, whereas other times it looks much more like a glioma with involvement of the cortex as well. It can be very hemorrhagic, very cystic and unusual appearance, or mainly just cystic with small amounts of hemosiderin lining and surrounding edema. And it can enhance, or it can have intrinsic high T1 signal. So in other words, it can look kind of like anything, and you have to be wary of the possibility of previous radiotherapy if you're to avoid the trap. This case I include because of all of them, this is the one that would be the most unfortunate if you thought this was a tumour. And these are giant perivascular spaces, or tumour-factive perivascular spaces. And something that I think is really worth remembering is that when you see a large lesion anywhere in the body, but especially in the brain, staring at the centre of it doesn't give you the answer very often. The answer's at the margins of it, and that's why having a stack when you're studying from to scroll to the edges of the lesion is really helpful, because it's these little lesions at the edge here that look just like the big one but smaller that you would have no trouble in calling a perivascular space. That one even has a vessel running through it. Typical location, lower half of the basal ganglia, no peripheral edema, no gliosis, follows CSF on everything, and can be amazingly large. They don't tend to have a great deal of mass effect for their size. If you note, there's not too much compression of the adjacent brain because this is a very slow process. They can occur anywhere. Where they normally occur is typical, but they can also occur in the brainstem, very distorting, where you wonder how the patient's asymptomatic as there doesn't seem to be any room for descending tracts, or they can be along perforating vessels of the cortex. So that's the first session concluded. Now over to Dixon.
All right, so great session on intraaxial and extraaxial masses. There's going to be a little bit of a lag with my slides because I am using relying upon the internet. I love the concept of epicenter not being relevant in the brain. The first thing that a registrar or a radiologist wants to do when they see a big mass in the brain is decide whether it's intraaxial or extraaxial. And I think when you see a really, really big one, it's very hard not to think that it's sitting right inside the brain. Okay, but you've got to remember that it may have come from the periphery and it's growing in. Okay, so the epicenter not being relevant, I've never heard that expressed in that kind of way before, so I think that's something to take away. We did get a little bit of Twitter activity. Henry just wondering whether tumour juice is an actual term that should be encouraged in radiology and in the exam setting. I think it probably is. I think Frank used it in the context of the meningioma creating that CSF cleft sign. And I think if you think about the CSF cleft sign a little bit more, you know, you've got the brain parenchyma, which is being squashed by this massive meningioma. The CSF is really effaced everywhere else. So the fact that you've got this quite thick rim of hyperintensity there, it doesn't make sense that that's only CSF. Okay, there's something else in there. Okay, and that's this CSF juice. It may be a little bit of brain tumour interface reaction. Okay, so I think it's worth knowing that it's not pure CSF that sits between it, even though we call it a CSF cleft sign. Tumour juice, fantastic term. Another tweet from Bruno picked up on a point that I wanted to emphasise as well, which is the difference, or something that can help you determine whether something is a meningioma or more likely to be a hemangiopericytoma. And the fact that the hemangiopericytoma tends to grow directly through the dura and it grows through the bone as well, whereas the meningioma tends to have a slightly different pattern. Just have a look at those images that Frank used again. Here's the meningioma, and you can still see the cortex of the bone on both sides. You can still see the bone marrow. So that tumour is, even though it's got extraosseous extension, it's respecting the cortex, okay, and moving through that bone rather than destroying it. The hemangiopericytoma, however, complete destruction of the bone. No remnant of that cortex there. The other point he made was that microlobulation of the contour for hemangiopericytomas, and the difference in blood supply, the parasitization of blood supply from the periphery in the hemangiopericytoma, rather than that spoke wheel, central vascularity that we saw in the meningioma. Meningioma cysts was something I'd never thought a lot about before, so I thought I'd emphasise that as well. You don't see them that commonly, but you do see them. And the different types worth being aware of, these ones where you've got the enhancement around the periphery of the cysts, implying that is still part of the tumour. Those cysts are within the actual tumour. The surgeon's going to need to resect all of that cyst, compared to this reactive, adjacent kind of arachnoid cyst next to the meningioma. Surgeon doesn't have to remove that because we can't see any enhancement going around that. I thought that was a very good point. And I really like the microcystic meningioma, that really bright T2 hyperintense meningioma. We always think of them as being iso-intense on T1 and T2. A really bright T2 lesion that's extraaxial can be a microcystic meningioma. These bleed at surgery and may be amenable to a preoperative embolization. So these cysts in meningiomas have surgical implications, so worth being aware of. This is another statement, a little quote from Frank that stuck with me. The glioma extends throughout the region of T2 hyperintensity and often 1 to 2 centimetres beyond it. I think there's a tendency for people to describe the white matter hyperintensity as being vasogenic edema, whereas that might be the case if you're dealing with a metastasis. But if you're dealing with glioma, the white matter hyperintensity is actually tumour cells, and in fact, even beyond that further, is tumour cells. Has implications for how you report a study. Instead of saying vasogenic edema is seen surrounding the lesion, you want to be saying things like there is T2 prolongation or T2 hyperintensity within the surrounding white matter. Okay? Try not to commit to the term vasogenic edema. I like the emphasis Frank put on looking for the thickening of the cortex, the T2 hyperintense thickening. Really important in tumour follow-up because you're going to get hyperintensity in the white matter after you start treating something with chemotherapy and radiotherapy after you've done a resection. But you're not going to get cortical thickening, progressive cortical thickening. That implies there's still tumour around. So I think that is worth remembering. I think I added in one of my cases. Yeah, here's a case of a person who's had a GBM resected here. Here's the resection cavity, okay? And we've got this T2 hyperintensity over here, involving the cortex, expanding the cortex. There's no way that can be a treatment response, radiation related. This is going to be more glioma. And as Frank said, it's a low-grade tumour that then can transform into the high-grade tumour. This is another area of low-grade tumour which needs follow-up. It may well transform like the other part did. I've already emphasised that, choosing your words carefully. The other way in which you should be careful with your words is when you're reporting a post-operative study and you might say there's no residual tumour because you're not seeing any more enhancement. It's really important, obviously, to say no residual enhancing tumour because we know the T2 hyperintense areas are tumour. Okay, so just be careful with your word choice when dealing with gliomas. If there's one number to remember today, it's 745 plus or minus 135. No, you don't need to remember that number, but I think the concept of higher grade portions within a tumour having reduced ADC is worth knowing. And I think the rough idea that if the tumour ADC value is returning down to that of the normal white matter, which is around 800 in terms of its ADC value, if you're seeing regions of tumour that's returned towards white matter levels of ADC, then that's probably going to be high-grade tumour, and it can help direct the treatment in terms of biopsy. So ADC values are going to come up a few times today. I love this mystery case because I would have reported this as being metastases, but I've never really thought about that concept of it tracking linearly through the white matter. I have seen a metastasis in the corpus callosum. I saw one just the other day. It was melanoma, and melanoma can do pretty much anything. So, but very rare for a metastasis to be in the corpus callosum. So that's the first clue, and that perfectly straight line. Multifocal versus multicentric. If you've got T2 hyperintensity throughout the whole area with multifocal regions of enhancement, that's multifocal. That's one process. If you've got complete separation, no T2 hyperintensity between the two areas of enhancement, then that's multicentric. Okay. The only other tip that I really liked for the metastases was we can be confident in metastases if there is hemorrhage within it. So if it's got this uniform T1 hyperintensity throughout it, that's not going to be a GBM. GBM may have little micro hemorrhages here and there. It's not going to have this uniform hyperintensity on T1. Oh, grass fire. I spent most of my time sitting there trying to find an image of grass fire. When Frank described the tumefactive demyelination, so that enhancing margin as the demyelination spreads through the white matter, and he likened it to this grass fire, and I think it's a fantastic analogy. You've got that enhancement on the periphery, but then you've got this area of burnt out centrally, which is not going to enhance anymore. And it reminded me of one of my cases. And this case, you initially look at this and you think it could be lymphoma. It's a periventricular lesion, and it's very, very vividly enhancing. You know, Frank mentioned that tumour factor demyelination can be faintly enhancing, but it can also be vividly enhancing. So periventricular, vividly enhancing, you think, oh, this could be lymphoma. But if you look at this carefully, you've got multiple kind of areas of the like the grass fires going on, another grass fire here, and it burns on multiple fronts. It's not just one grass fire heading out, it's multiple grass fires coming from one spot. So it's arising from and travelling away from a region of grey matter. So the bit of non-enhancement is going to be on the grey matter aspect. So if it arises in the subcortical U fibres, the non-enhancement is going to be on the cortex side, and the enhancement is going to move away towards the ventricle. If this is arising in the periventricular location, then it's going to move away towards the cortex, the enhancement. I think that's a fantastic analogy. In this case, you'd be very tempted to think about lymphoma. The other thing that is against lymphoma, obviously, is the fact that this has very, very little mass effect. If you had a lymphoma of this size, you'd expect some edema around it, and you'd also expect quite a bit of mass effect. Okay? ADC, just to emphasise the importance of ADC, look at that beautiful peripheral leading edge diffusion restriction. So the grass fire, I really, really enjoyed. Never heard that term before. I've heard about the open ring enhancement sign, but never heard of a grass fire. And my final point is, I think what you can really take away from intraaxial and extraaxial masses is there are times where you can be definitive, but there's also times where you can't. And the times where you can be definitive can really change the management of the patient. So you should be able to very confidently say this is lymphoma because it's fairly dense on CT, it vividly enhances, it likes that periventricular location or the cortex, it has diffusion restriction. Okay, so you should be able to come down very hard on lymphoma, and as Frank said, sometimes the biopsy is non-diagnostic if they've already had steroids, and so you have the ability to stop the patient having excessive surgery by saying this is lymphoma. Same with tumour factor demyelination, as we've seen, you can come down hard and say, I think this is demyelination. Giant perivascular space, I think we've had a case at the Alfred a few years ago where there was a giant perivascular space. We reported it as such, neurosurgeons weren't so confident, went in, biopsied or took a sample and caused a complication at the time. Okay, so very important to be confident in that diagnosis. We haven't come to cerebral abscess yet, but that's the fourth one that I think you can really, as a neuroradiologist or a radiologist, come down hard on, is this an abscess or is it not? Because it's obviously going to expedite the patient's care if you think it is an abscess.